Thanks so much for inviting me to participate. And as we were talking before, I so look forward to the day that we can all meet each other again in person. But it's a real honor to be invited to speak today. And it's that case was a great segue into the topic that I've been asked to talk about, which is new approaches to neoadjuvant therapy. Rectal cancer has undergone tremendous evolution. This is a really good time to be somebody who is interested in rectal cancer. There has been so much progress. There's still so much to learn, so much to study. But historically, the big problem with rectal cancer was that we had a lot of local failure, and a lot of treatment innovation has happened in order to try to decrease that risk of local failure. This has included radiotherapy, chemoradiotherapy, etc. But we now know that with advances in surgery, with optimal use of neoadjuvant therapies, we have really conquered the local recurrence problem for the most part. It's still an issue, but the bigger issue today is distant failure. And now we are transitioning our treatment strategies so that we can try to start to address that distant failure. And this now includes expanded regimens during the neoadjuvant treatment phase, and that's what we're going to talk about today. So we're going to talk a little bit about some of what we've already mentioned, short course versus long course radiotherapy, because it's still a relevant question today. Just very briefly touch upon neoadjuvant chemotherapy. We need a little more time for the data to mature, but that alone gives us some information. And then we've been hearing about total neoadjuvant therapy and how it should be utilized. So everybody is very familiar with this data, which is the Dutch TME trial. We give radiation because we know that even with total mesorectal excision, that we can improve outcomes by the addition of radiation. And in this case, this was 5x5 short course radiation and surgery the week after. And since then, we've also had the German rectal cancer trial that tells us that preoperative treatment is better than post-op. So that was one of the options, surgery and then figure out what to do. That is clearly not a good option. And we see that with preoperative chemoradiation versus post-operative chemoradiation, much better local control. And in fact, if we don't give anything because the patient couldn't get it, as an example, they have much, much higher rates of local failure. So neoadjuvant therapy improves outcome. So those trials used short course in the Dutch trial, the conventional long course chemoradiation therapy in the German trial. And of course, and the big question becomes, is one better than the other? Historically, there was concern about toxicity with short course therapy. I think that really had to do with the fact that we had better data for short course. And we know now from a randomized trial that compared 5x5 short course versus 50.4 gray long course in the trans-Tasman radiation oncology study group, that the morbidity was not different, and that we actually have good oncologic efficacy. In other words, short course or long course is oncologically essentially equivalent, but you can see that we get more complete response with long course therapy. So that prolonged treatment course and the time to delay allows tumor regression, something we don't get if we operate immediately after. And so that question of could we give short course and wait to get treatment response, because now we all recognize treatment response is highly desirable, was tested in the Stockholm 3 trial. And in the Stockholm 3 trial, it was 5x5, sort of the European 5x5 radiation, followed by a delay to surgery, no additional chemotherapy, just a delay. And here we can see that now we can, even with short course radiation therapy, we can achieve pathologic complete response. So allowing the radiation to exert its effect appears to have benefit. So when we think about short course versus long course, there are many factors that are really involved. We now know that that the overall toxicity is similar or is not particularly different. And we know that the oncologic efficacy is also equivalent. And so now it becomes a matter of trying to figure out what is the right treatment for that particular patient. But there are many advantages of short course therapy. It's much, much more efficient. We can treat many, many more patients. It costs much less money than giving conventional long course. And so I think increasingly we are going to see much more short course being utilized but in combination with a delay to surgery or with additional treatment. And we'll talk about that. So I'm going to move on to this concept of this concept of neoadjuvant chemotherapy and transition to the concept of total neoadjuvant therapy. But why are we interested in neoadjuvant chemotherapy? We talked about the fact that in rectal cancer, the big problem today is distant failure, no longer local control. We've figured out local control to a great extent. And if we give the chemotherapy that we would normally give after surgery, if we give it up front, we know that patients tolerate it better, that there are higher rates of treatment completion and there's less toxicity. We also know that by giving more treatment preoperatively, we can increase treatment response, and that allows us to have an in vivo test of the efficacy of the drugs. It also allows us for opportunities for thinking about novel treatment strategies such as watch and wait. And then finally, the other advantage of bringing the treatment up front could be that we can treat micrometastatic disease earlier. In other words, instead of waiting essentially 3 or 4 months to finally get to systemic treatment, we're delivering that treatment up front and in the setting of an undisturbed tumor. So potentially we can decrease the risk of micrometastasis that subsequently develops into recurrence. Just since we're talking about what's new in neoadjuvant therapy, only one slide to talk about neoadjuvant chemotherapy alone. There have been 3 trials, and in fact, the most recent trial and the largest is the US intergroup prospect trial, which was randomization of chemotherapy alone versus chemoradiation. And that trial completed accrual now a few years ago, but still cannot report because there have not been enough events. That tells us that there appears to be efficacy with neoadjuvant chemotherapy alone in those selected patients, and is probably not that far away from the data from China in the FORWARK trial, where we see that local control with chemotherapy alone versus chemoradiation or intensified chemoradiation with FOLFOX-based concurrent chemotherapy, that we don't have an increase in, that the local control is not different, that overall survival is also not different, along with disease-free survival. So well, I think increasingly we're going to see there's going to be a group of patients that don't need radiotherapy, that are going to get chemotherapy alone, but we need a little more time for this data to mature. So we mentioned earlier about then the strategy of giving chemotherapy in order to improve treatment compliance along with radiation before surgery. And this was a landmark phase 2 trial by the GEMCAD group, looking at giving induction chemotherapy, so CAPOX for 3 months essentially, followed by chemoradiation, versus the traditional treatment of chemoradiation followed by surgery, followed by adjuvant chemotherapy. And we can see that the rate of grade 3/4 toxicity was much lower by giving induction therapy. So this is a precursor to our modern TNT. So better tolerated in terms of toxicity and higher rates of treatment completion. And we would argue that increasing treatment completion potentially would improve disease control. And that has led to a variety of other approaches. And in the US, we have a phase 2 platform trial looking at the traditional now, what most people consider traditional TNT, which is 4 months of induction chemotherapy with FOLFOX, followed by chemoradiation. And in this platform trial, a variety of different agents have been utilized in order to try to increase the rate of response. A PARP inhibitor, veliparib, as well as immunotherapy with pembrolizumab. And these data have just recently been reported, but unfortunately we see that so far we have not been able to increase the rate of treatment response, the so-called neoadjuvant response score, or the rate of pathologic complete response. Here we see comparing the veliparib versus traditional chemoradiation with capecitabine-based chemoradiation. Not a significant increase in pathologic complete response. Here's immunotherapy versus conventional capecitabine-based. Again, not a significant increase in complete response. But take note that these are relatively high rates of pathologic complete response. That's actually quite good. 30% is actually considerably higher than what we have come to expect historically. So now that we have this concept of induction therapy-based total neoadjuvant treatment, the obvious next question is it better to give the chemotherapy before the chemoradiation, or is it better to give the chemotherapy after the chemoradiation? And that's exactly the question that was asked in the randomized phase 2 more recent German rectal study group trial, which randomized patients either induction versus consolidation. This is a slightly different dosing scheme for the oxaliplatin than we utilize typically in the US. And therefore, the patients got concurrent oxaliplatin during the radiotherapy as well. Again, a lower dose of oxaliplatin. And then the patients ultimately went to TME. And here we can see that the pathologic response rate was higher in the consolidation group, so giving chemotherapy after the radiotherapy. And also there was a slight increase in the rate of chemotherapy completion and the ability to receive oxaliplatin. And therefore the conclusion based on this was that consolidation was superior. And in fact, this study was designed to determine how the German rectal cancer study group was going to design future trials. And so future trials in the German rectal cancer study group will use consolidation chemotherapy as its total neoadjuvant treatment standard. And of course, there was a mention of this by Dr. Arruda earlier, Julio Garcia-Aguilar. I'm sure he's going to talk about this later today. In the OPERA trial, he compared by randomization patients to get induction versus consolidation, and was looking to see if patients could undergo organ preservation. In other words, did they require surgery? Did they have clinical complete response? And could they undergo watch and wait? And subsequently, did they develop treatment failure? And here we can see one of the most clear evidence today of the superiority of consolidation versus induction. And so in the consolidation group in red, there was a significantly higher rate of TME-free survival, so ability to keep their rectum. And so this demonstrates that consolidation is superior to induction if our goal is response, if our goal is clinical complete response, because there was no difference in disease-free survival by either arm. So now that we have some concepts around TNT along with induction versus consolidation, the next question is, again, we have to get back to what is the primary concern? It's distant failure. Can we reduce the rate of distant failure? And so the French intergroup in the Prestige 23 trial asked this question: can we increase the intensity of our chemotherapy so that we can, with a goal of decreasing recurrence rates, decreasing metastases? And can we increase the intensity of our pre-operative chemotherapy and improve response rates as well? But the primary goal here was disease-free survival. Here we can see patient characteristics. They were a relatively advanced group. Again, like our conversation, node negative, margin clear patients in Europe typically will go straight to surgery, not necessarily get neoadjuvant therapy, which explains why 90% of the patients were clinically staged node positive. And so patients received a triplet combination of FOLFOXIRI or FOLFIRINOX, 5-FU oxaliplatin and irinotecan, a regimen that we use not uncommonly in patients with metastatic disease, but use this triplet regimen with 6 cycles followed by chemoradiation. So induction therapy, so a traditional TNT model, followed by induction, followed by chemoradiation, and then surgery. And this was just reported in ASCO last year, and really kind of has really turned around or completely changed in many ways our thinking about rectal cancer, because for the very first time, we now have a study that demonstrates that we can improve disease-free survival by our treatment sequence and by our treatment strategy. And so whether it was the neoadjuvant approach or the intensification with FOLFIRINOX that resulted in the improved disease-free survival, we don't have that answer. But at least in this trial, we don't have that answer. But you can see there was a clinically meaningful improvement in disease-free survival. Not a major difference in overall survival, however, but there were some other interesting findings. For example, there was less grade 3+ toxicity associated with a neoadjuvant versus a traditional adjuvant approach. And there was also a lower rate of non-therapeutic laparotomy. In other words, there was potentially greater downstaging, resulting in more patients ultimately being able to undergo R0 resection, although that difference was only 4%. Another really interesting finding from this study was that when we look at impotence as a single outcome, while there was no difference in overall quality of life, there appeared to be improvement in recovery of erectile function in the experimental arm. So induction, even though the induction therapy was more intense, TNT was associated with better functional outcome, which of course is an outcome that's very important to our patients, but again adds a lot of interesting color to this concept of TNT. So we talked earlier about long course and short course. Does this mean, based on this data, that now everybody has to get long course? Well, the Rapido trial that was conducted by our European colleagues asked that question. Instead of doing the Swedish study of 5x5 and waiting, could we give chemotherapy? Can we consolidate with chemotherapy? And what would then be the outcome? And so the Rapido trial also has been really a landmark study and has really changed for many of us the way of thinking about rectal cancer. This is a very unique study in the sense that only very high-risk patients really were treated because, again, in Europe, the treatment standard, low-risk patients often will go straight to surgery. You can see by the rate of T4 disease, a third of the patients were T4, 2/3 of the patients were N2. These are locally advanced cancers. Despite that, the R0 resection rate was very high, even though 2/3 of the patients had clinical evidence of CRM involvement on MRI. So this is a testimony to the quality of MRI, and this is a testimony to thinking about a treatment strategy for patients with locally advanced disease. And also, a number of these patients had EMVI, a third of the patients, so clearly a high-risk group. And so the randomization was 5x5 followed by 4 months essentially of CAPOX therapy, so capecitabine and oxaliplatin, versus traditional long course chemoradiation followed by optional adjuvant therapy. And here we again see that we can improve in this high risk population. First of all, we can improve pathologic complete response. Nearly a third of the patients achieved pathologic complete response, 28%. There was no difference in the type of surgery, no difference in the rate of R0 resection, no difference in postoperative morbidity despite all of the preoperative treatment. But there was a 7% improvement in the distant metastasis rate with a short course TNT approach. So it appears that we can achieve similarly good outcomes with using short course radiation-based neoadjuvant therapy when it's combined with consolidation chemotherapy. So, and even in this very high risk group setting. So what can we learn from all of these trials that we've had so far? Well, in 2021, we should all be thinking about a variety of different approaches. And 5x5 is an absolutely valid approach. 5x5 and delayed surgery is an alternative to long course chemoradiation. It can achieve pathologic complete response. The morbidity rates are not higher. Sometimes we're a little reluctant to give high dose for fraction directly on the anal sphincter. I think this is if we're going to do sphincter preservation, and I think this is something that we'll need to continued study about. Preoperative chemotherapy is associated with improved treatment adherence, lower toxicity, improved distant recurrence free survival, and improved resectability and better quality of life. And then 5x5 TNT strategy should be strongly considered for high-risk patients, as we can see the excellent outcomes. So this is my last slide. This is our approach. If patients are low risk, they should go straight to surgery. If they're intermediate risk, they can get long course. We can assess the response and consider consolidation. If we're early T3, we're trying to do sphincter preservation, such as intersphincteric resection. Again, long course would be appropriate. If it's intermediate risk, higher in the rectum, we might consider chemotherapy alone. So a variety of approaches for intermediate risk. But for those high-risk patients based on MRI, then we would utilize a TNT approach. And at MD Anderson, we would do this with 5x5, either a Rapido style or our MD Anderson sandwich, which is a sandwich induction 5x5 followed by consolidation. Thanks very much for your attention.
Thank you.